Lucy Knight, Chair of the Committee, and I will be chairing tonight's meeting. This event is streamed live on YouTube, and members of the public and the media are welcome to watch the meeting remotely and listen to the session taking place. Now, I'd like to welcome you all to Committee Room 1 at Kensington Town Hall and everyone watching on YouTube. Before we proceed with this meeting, I would ask that everyone present please make sure their mobile phones are either on silent or switched off. And we will start with a 72-second silence to remember those who lost their lives in Grenfell tragedy. Starting with agenda item 1, apologies for absence. Haven't received any apologies for absence. And I just know that Councillor Ahmed is leaving slightly early. Agenda item 2, declarations of interest. Does any member have an interest in that? And then agenda item 3, minutes of the meetings held on the 6th of February 2025. The minutes of this meeting held on the 6th of February have been submitted for confirmation. Does the committee agree for them to be signed as a correct record? Moving on to the first item, which is the cancer screening paper. This item focuses on outcomes and effectiveness of cancer screening and services for various patients. The report has been jointly produced by the NHS England, RM Partners Cancer Alliance, North West London ICP, West of London Breast Screening Service, and West of London Bowel Screening Centre. I just wanted to start by saying that obviously I think it's a great concern, the cancer screening figures for KMC, and we are very concerned about them. And obviously, despite being one of the wealthiest boroughs, with the lowest screening rates in England, for breast, cervical, and the second lowest for cancer. And the report points out major issues. There's population churn, inaccurate GP lists, the impact of private healthcare and workforce shortages, but even so, scale of underperformance is pretty stark. So I think it'd be great to hear what you have to say on this, and our focus as a committee tonight must be on understanding why these gaps exist, how the NHS is working across primary care and hospitals to fix them, and what urgent action is needed to make screening more accurate, accessible, and equitable, as ultimately this is about saving lives. So I wanted to start by inviting Rachel Krause and Anna Raleigh to introduce this book. Introducing it, and then also it'd be great if everyone generally introduce themselves to the committee, because I know there's lots of people here today.
So if I just make a start. So my name is Anna Raleigh. I'm the Director of Public Health for Royal Borough of Kensington and Chelsea. A couple of colleagues are poorly tonight, so they're not here with us in the room. So Rachel has sent forward her apologies, and also Dr. Josephine Rwande has sent forward her apologies, but we're joined on a screen by her colleague Pamela. So thank you very much, Pamela, for joining us tonight. So it's really quite short notice. I think it will be quite helpful for colleagues to introduce themselves, but I'm just going to start very much by saying that screening requires a system-wide approach. It requires us all to come together to play our roles in different parts of the system. It's an incredibly fragmented system, and that creates much of the complexity around it. And thank you very much, colleagues, for the paper, which I think helps make sense of that very fragmented system. The role of a local public health team is around assurance and oversight. We also do play a role as well around community engagement and supporting the local system. We're joined by our colleagues, Pamela on screen, NHS England, who are the commissioners of screening services. We're also joined by NHS colleagues here in the room today, primary care colleagues who provide some of the screening services, and we're also joined by our systems colleagues as well here in the room. You set out our local challenges very well, Councillor, so I won't repeat that other than to say our rates are low, much lower than we would like them to be or we would expect them to be. Yes, there are challenges around being in a London borough, particularly in relation maybe to population churn, a diverse population, private healthcare, access, etc. But even with those challenges, I think there are opportunities for us to do better as a system, and I hope the paper will set out some of those opportunities as we move forward. For example, working at a hyperlocal level, community engagement, addressing really some of those barriers to access with our local residents within the community around educational training support. There's some very new exciting pilots that I think we might hear a little bit about, and they'll set out within this paper. So around self-testing, which I think will hopefully be acceptable to a broad range of the community and foster greater engagement and screening moving forward. That's particularly for survival screening. But there are also some risks on the horizon. So with the integrated care system reorganising locally, there's some concern about the impact that might have on our local plans, particularly on local survival screening plans, and really keen to understand what infrastructure may emerge from the reorganisation that's going on at the moment that would be able to support that really concentrated, hyper-local, joined-up approach that goes right from the top down to how we work with our residents on the ground. So if I invite maybe Andrew, Naomi, and then Susan and John, and then I think I'll be over to Pamela.
This is just as an introduction. Yes, my name is Andrew Stephen. I'm a local GP. I work in South Kensington, but I'm the Borough Medical Director for West London, and I work with Naomi.
I'm Naomi. I'm a GP actually in the north of Westminster, but I work with Andrew as the clinical lead for West London Borough. And I'm going to be talking a little bit about also what we've done under our GP Federation to try and improve access to smears and other screening programmes within the borough.
I'm Susan Sinclair. I'm the Managing Director of RM Partners Cancer Alliance. The Cancer Alliance covers the whole of North West London and the whole of South West London, and what that enables us to do is really think about the populations we're trying to hit. So for cervical screening, we know that young women, in particular, if you're under 30, across RM Partners, you're less likely to have screening than having. It's about 50% uptake. And I think for that reason, we are really excited about the South swabbing, because the literature is showing that is something that's much more acceptable to young women. And that's something that we'll be working with NHS England to support locally in practices with the lowest uptake, where we think they'll get the biggest win. The other thing RM Partners is responsible for directly rather than the support for is rolling out the lung screening programme. This has got a really big win for lung cancer. Most lung cancers don't really present very early because the symptoms take quite a long time to present, by which time the cancer is quite advanced. But so our early stage diagnosis is about 25 to 40% nationally for lung, but via screening, we've got that up to 75%. And we started our rollout in KNC last year, and we are with an uptake of 47% on the first round. So that's something that, and what we're also using that to do is help with smoking cessation, because obviously what we want to do is stop smoking and tobacco usage. The other thing that RM Partners is supporting in terms of cancer prevention is the eradication of cancer. So we talked about cervical cancers. Most cervical cancers are caused by HPV virus, and the HPV virus is essentially prevented from causing 4 types of cancer through the school age vaccine. And that's something we're engaging with the new vaccine provider. We've done some work directly with communities and found actually the awareness of this is really poor. and they don't understand that it's one vaccine that gives you sort of a lifetime protection for most people. So that there's work that we're doing that's going directly to communities and teenagers about that vaccine. I think the other thing just to note is that the areas, what we have been doing over the last few years is really trying to get some of the primary care pieces, particularly for cervical screening, which is the test that's actually done in primary care, and work through. So we've had we had a relationship, and we've engaged with somebody called Catch-22 to really visit GP surgeries and support, and that's come to an end. And we've now working with one of the clinical leads in North West London, who's a nurse, and we're just working through the boroughs that she needs to really focus on to see a step change on, try and do everywhere. And I think it's very likely that this one will be one of those, and then that will be something that happens over 25-26.
Thanks. So I'm John Birchall. I'm the programme lead for prevention and screening for RM Partners, which is a fairly new post. But for the last 3 years, I've been running out the lung cancer screening programme that Susan mentioned. And then Susan said we went live with that in KNC in September last year. 47% is where we're at in terms of the uptake, which is a lot better than we were with the pilot, and is actually a national standard for lung cancer screening. It's not the ambition, but this is the first round in KNC. And so I think from about 22,000 people who are eligible in KNC, we've already invited over 8,500 people who are eligible. Previously, prior to working on lung cancer screening, I had a lot of experience working as a senior project manager at Government Partners on many screening initiatives. As Susan also mentioned, there's a lot of work that we did with organisations such as Community Links, who they will call non-responders for bowel, breast and cervical screening. We actually put quite a lot of money into developing this programme because Community Links have a wide range of people from different backgrounds who speak a lot of different languages. So they could encourage people in their own language to come for screening. I think we're moving away from that model because we're realising it's not a sustainable model in terms of the cost of calling all those non-responders. So what we're looking at now is really concentrating on working with our system partners on how we can work together to increase the uptake of screening. And we also have developed with our business intelligence teams databases that we are now rolling out to access to all our GPs and primary care nurses, where they can look at the screening uptake for the local population, and they can overlay it with the other illnesses that the patients may have, and the languages that they speak, and the ethnicity that they are, and the deprivation. So what we're looking at is how we work with our system partners to do targeted approaches towards how we get those people who are not being screened.
Thank you. And Pamela.
Hello, everyone. Can you hear me? Okay, good evening. My name is Pam Jawi. I am the head of adult and cancer screening for NHS England London region. And NHS England is responsible for the commissioning, the contracts and performance management of Section 7A screening programs, of which the cancer screening programs are part of. So we work directly commissioning most of the screening programs, including working with the providers, overseeing performance and quality, looking at things like incidents and risks, implementing new program pathways, and a few other things. And also we have public health oversight and expertise in Dr. Joe Rende, who's not able to join us today. So that's kind of an overview of it for now, if that's okay.
Anyone else want to?
We're just doing introductions before, but we're happy to kind of talk about a bit what's going on in primary care and general practice. So first of all, it's a multi-pronged approach. We completely agree with your concerns, and we all share the concerns about how we work and how we actually do it on the ground is key, and that's what you really want to hear today, I assume. So first of all, we can send out SMS messages to all our patients. Those SMS messages can be much more exciting today. We send YouTube links with nurses explaining what a smear test is, how important it is. Please, can you watch this and book your appointment, this link. So you can send a YouTube video followed by a link to book the appointment should you want to. We can send that in multiple different languages. Try that. I have to say that YouTube we thought would have brilliant uptake. It actually didn't increase our uptake, but other things have. We have the kind of blanket approach of sending emails and sending SMSs to people every week, every other week does increase uptake. It's called the kind of scattergun approach. Oh, I'll do it. All this, and also changing the day of the week and the time of the day that you send the invitation. So then being able to choose when their appointment is really very key, right? Because if they have to phone reception, find out what time the appointment is, all of that's really frustrating for people. So that's another approach we've taken. We've also taken an approach that the LMA, which is our GP Federation, has smear clinics at Barnet Mountchard and at St Charles all day Saturday, all day Sunday, and every weekend. Patients get invitations from those links as well as from their practices, so they can choose. Do you go to the practice? Do you go to the hubs over the weekend? So it's not like we're not inviting, we're really offering. But what are the challenges? Some people, we're in central London. Okay, there are lots of excuses. People come in, people come out. I'm not convinced it's that the GP lists aren't quite right. I actually do think that a lot of patients want to go back home to get their smear. They trust their gynae back home. We get a lot of this. I had it done back home, but I don't want to have it done again here. I only had it 2 months ago back home when I went to visit my parents or something else. So we have a real challenge with that. We also have a challenge, obviously, with the private sector, is that even if they give us the results, it doesn't quite work. Even if the result has gone through the same lab, it doesn't come up to it. So those are the challenges. The other challenges is we have a large Muslim population, and they do not have smears before they've had sexual intercourse for marital reasons, and therefore a lot of people refuse to do this prior to marriage. So you kind of have to catch them in that window of opportunity, because actually by the time you see them after marriage, they're generally pregnant and you can't do the smear then. So we book them all in at this 8-week check. We book them in for smears at 12 weeks, but that does delay things for a lot of people. Okay, so we've also looked at different groups of people that can be smear takers. So traditionally that was always nurses, but now we have physicians associates. They can also do smears. So we've trained up a huge number of people to do smears. They have to do huge numbers. There've been lots of controversy about physicians associates in practice. There's no controversy about them doing smears, right? And it's actually more access. And if we can't get a nurse, we can put a physician associate across any of our practices to do that. So that's another skill mix that we've done. The final thing that I just want to say is the lung screening. You've mentioned how brilliant it is. I can't reiterate it enough, because it doesn't just pick up lung cancer. It picks up emphysema and coronary artery disease. And so actually the fact that we've almost doubled our COPD list sizes because of the lung cancer screening. I personally haven't seen anyone with lung cancer, but so many people have we been able to say, okay, you've got COPD, you actually have to now stop smoking. This is no longer a conversation. And actually, getting a diagnosis of emphysema really does change people's mindsets. And so I think it will not necessarily pick up lung cancer, but it will prevent the lung cancers coming on and people going into hospital for severe respiratory disease that we're not kind of discussing here. Also, when you see their coronary arteries are clogged, you either send them to a cardiologist or you start doing very rapid cardiovascular risk factor prevention, blood pressure control, sugar control, cholesterol control, and you can change the way you do things in a way that isn't cancer related, but is actually helpful to our patient population. And I think that it'd be really lovely to see the results of that going forward, because I think that's going to make a huge difference for our population here.
Does anyone else have anything they want to add before the committee asks questions? I think I was just going to start by saying, sort of laid out the challenges, which we've obviously read about this report as well. But how confident are you that firstly we can change things around, but also that it is due to those specific reasons that we are the lowest performing country boroughs in the country, or are there other factors, e.g. sort of coordination and cooperation partners together? I mean, how can we have confidence that these figures are going to turn around? How are we going to see them happen rapidly? And I mean, I think these rates collapsed sort of well before COVID. So why have they remained low for so long, and sort of has the recovery been so slow in comparison to other areas?
Yeah, you go.
So I think it is very, very complex, and it's no one thing. I think it is lots of little elements kind of coming together that causes the complexity in the system. I do think that there is more we can be doing on the ground level. We've certainly very much changed how we work with the local communities moving forward. We've recently launched a programme which is called a Healthy Communities Fund within the Royal Borough of Kensington and Chelsea. That is very much about training up local voluntary sector organisations to have conversations with people about health, and to ensure that they are provided with the education and the skills to dispel myths and to encourage people to come forward. So a lot of that work on the ground around having the conversations in the communities, having community leaders who are knowledgeable about health, people trust, being able to have those conversations, I think is very important. And I think then what layers over that very much is access. And Dr. Katz described really well a lot of the work that is taking place to improve access. I think there are still challenges in that space. I think for many people, accessing the health service can be quite daunting, and what seems kind of quite straightforward to us, or what seems like lots of routes to us, does not necessarily feel like they're often to the resident on the street. So there is always work that we need to do to explain those access routes, and that's why the work of the voluntary sector that we're doing is so important, because the more knowledge we have out there in the voluntary sector about those, the more important it will be to kind of move this forward and to move how we're working together forward. I think we're looking at creating more staff who are trained to undertake particularly sabbatical smears. I think that's a really positive step moving forward. We do know that there have been challenges with having enough trained nurses to provide that service moving forward. So that increase in capacity is going to be welcome. There's possibly some work around kind of modelling what good access would look like, good capacity would look like to ensure that is adequate. I think there's real opportunity with some of the new initiatives coming forward. They'll be very attractive to a range of population with the early work that's been done. I think there is opportunity maybe to do more with sexual health services, and ongoing conversation with NHS England is kind of why can't our gun clinic screen, and why can't that screening then come into our services? Because whilst you have people in clinic, it's a wonderful opportunity. So to be able to take a smear at the same time will make an awful lot of sense. And we've been advocating that for some time, and I know there were some pilots. I might want to say a bit more about this in some parts of the country, I think particularly on the south coast, to look at this as an option, but we haven't seen that happen uniformly, and I think that's something that would be very welcome and could make a difference. So there's lots and lots of things we need to do to have impact and change. And I think one of our big challenges is the fact that the system is so fragmented.
This, I mean, it is a real challenge, the figures, and they're always challenging, but they've been challenging for a very long time. And sadly, Westminster and Kensington and Chelsea have been towards the bottom of the kind of league table for a long, long time. So we've been looking at the reasons for decades for why this is the reason. completely agree with Anna that the disjointed way that we deliver care or offer care is perhaps a barrier. And I think we've got a great opportunity with the proposal around INTs and neighbourhood care and teams joining up together to deliver very bespoke care for the communities that they're looking after. Is a really good chance to make one offer that people can have access to. I think one of the examples in the papers that really illustrates how well LMA and Naomi's team with LMA and Anna have done is if you look at the screening rates in some of the poorer parts of the borough, they're actually better than in others. And I think that shows, I think people have really made an attempt to attack those barriers, to see what we can do to dismantle them. I think what it does also illustrate is some of those underlying differences that we have as being a borough in the centre of London will continue to play out. So I think we may always have an issue that we have to keep working on here.
Just one question before I bring it back to, which is just sort of in terms of us as a committee and sort of following our stats and improvements. I mean, do you have a kind of, when would you want to see? Yes, the changes we're making and the pilots we're having take this into. I know we've just been discussing this for the 10 of years,
Yeah.
but we've been lacking behind. Also, another aspect too is we've been talking. We've spoken about some of the pilots and some of the new methods of testing. Will we continue to have the funding for those? Do we have the workforce to be? If we're worried about our staffing, even for SMERS, do we have that capacity to be rolling out these pilots and new services if we are struggling with funding and stuff? That's just my main concern. So I think it's great, the new methods of testing that are available, but are they going to be rolled out permanently into the fund?
So I think in terms of what we're doing, I think as Andrew says, we've worked for many years on trying to improve it, and I think we've got a commitment from us that we will continue to do it until we see win. And I think that this is all marginal gains. But I think the things that are going to make a step change are the self-swabbing. There's really good evidence for that in the trials, and it stops a whole interaction that doesn't really need to happen, where the woman can just do this in their own home. And that's what we're really pushing for. And that completely liberates survival screening from even having to access an NHS person. I think with BOWL, the things that are going on there again will help in terms of uptake, because as it gets to a lower threshold in terms of the fit threshold that we use before we go to colonoscopy, and the age extension gets lower, it means that more people will have had a positive prevention experience through BOWL screening, which will encourage people, because we know the number one thing that will make people go is if their neighbour had a great experience or something happens. You know, the word of mouth is much stronger than anything we'll do. And then I think with breast, it's just worth noting that there is a new procurement that's in post, and that's got very that's happening at the moment. None of us are particularly involved with that. That's a commissioning decision, but the KPIs and expectations around uptake are radically different from where they are now. And I think that will put a much greater focus on uptake and coverage. So I think with all of this, I think it's hard because these three boroughs are fairly resistant. You know, we've all been doing this for a long time, and none of us have seen the results we exactly want. But we know that all of these things have to happen, and that we need to build in the step change through new technology to get there. So I think there is light at the end of the tunnel.
Pamela, just before I go to Roberto, do you have any other comments you would like to add to any of those?
Yes, please. So just picking up on some of those points. In terms of sexual health delivery of cervical screening, the sexual services are commissioned to deliver opportunistic screening of cervical screening. So people who are 10 who are due do have the opportunity to be screened through that. And that's something that we're monitoring. And I think Kensington and Chelsea, as one of the trusts, is delivering that service. So that's one of them. The other point is regarding the procurement for breast screening. That's coming to the end of moderation. So we should, by the end of May or early June, be in a position to know who the new providers will be, who will be awarded the contracts. But what's going to change when these contracts start in April 2026 is that they will be tariff-based, and the evidence shows that when we pay according to the number of people screened, that you tend to have better engagement with providers, better engagement with communities, and therefore increase uptake. So that's what we're aiming for with regards to that. I was also just going to mention, in terms of cervical screening, there is one service across London that is targeted at people who have experienced some kind of sexual violence in the past, who find it hard to access that. So we do have a service catering for that particular population, and that also is aimed to increase uptake. The self-sampling project is aiming to start this summer. Joe Rende is leading on that with partners, some of who are in the meeting today, and that will be around ensuring that women who haven't attended within 6 months of being invited, so that will include people who've never attended, have the opportunity to do a self-swab. And that's how it's going to start. I know the national team do have plans to roll out this self-sampling in the coming years. So that also should help.
I'm going to start with Roberto.
Thank you, Madam Chairman. I'd just like to drill down a bit into what Dr. Katz was saying about particularly private screenings. Firstly, to pick up on what you said, when somebody comes and said they've had it privately, you said it's not the same, or it's not as good, or
Nothing. It's not as good. It just doesn't work to count to our figures.
okay.
So it's there in the system.
Yeah.
They've done it, but it doesn't affect our figures, and
Yeah.
that's the problem.
Yeah. And so
this is a count of NHS queries.
yes, yeah, absolutely.
Yeah.
So
Which is
yeah.
ridiculous.
Oh yeah.
We've
So
been fighting this for
so I
years.
guess essentially it's what what I can't say your name, Dr. Steeden. You're saying, we're at the bottom of the leaderboard, but it's mainly because most of demographics in this are playing a totally different league. It's not necessarily our figures are so low. It's that some, slightly perplexed sitting here and having a report about it, because almost the data isn't really worth the paper it's written on.
Well, it is useful because it gives us a challenge and stops us being complacent. And what we have seen is a turnaround in the delivery of the offer in the north of the borough, where we had deprivation issues.
Yeah.
So I think there are things that we can learn from it. I think what you have to marry this data against is cancer outcomes. And are we finding cancers early? Are we treating cancers early? Are people dying in Kensington and Chelsea younger because of this lack of screening? And I don't think we've got that match up. I think people do quite well here from cancer, but that's a very complex picture as well.
As in, we're not dying as badly as these figures would suggest. We should. Yeah, exactly. So that's, I mean, yeah. So this is fundamentally we're here with this report that, as you say, there are parts of the borough where absolutely the work that's being done is great, but hearing something that's talked about, it's almost as if we would rather take these people from the private sector and put more pressure on the NHS just to bump up our figures. But I guess, so my question then is, again, talking about all these wonderful things that you're doing, the root cause of this, what can be done to try and stop it being so fragmented? How can we get that data and put it in? What work is being done to try and join things up rather than everyone working in silos?
So we spent years trying to find just a code that we could code, smear done elsewhere, smear done abroad, smear done privately. And the problem is, because people send you, your NHS GP, you're happy to do it privately and send them the results. I have no problem with patients doing that. But those codes don't affect the NHS figures. So doctors stopped using them because they just put it in their record. They didn't need to code it. And so I think the only thing that we could do is insist that every single private, every private consultant on all the streets around here send the NHS GP, and then it gets coded. And then we'd be able to prove to you where we know we are, which is not at 6%, but at a lot better, right? Yeah. And every abroad one. So it's both private and.
How do we do that? Is that something that we have to raise with Joanne Streeting, or is that something that presumably as a council we can't do anything about?
It's much bigger than us.
Yeah. So I mean, should this?
It sounds very simple, but obviously it isn't.
It's something so logical. It seems almost unbelievable that we haven't been able to. So I think it is something that we do need as much pressure as we can, because it's also not right to ask women to have unnecessary tests when they've been cleared in other sectors.
And it's the same lab. Previously, we were using a different lab to the private lab, but now it's all onto TDL. And most private providers use TDL.
Right. Yeah, I mean, yeah, it's not your fault, but it's sort of, it just seems like to me, I'm reading this and it seems like a joke. That you know, and like I say, we're clearly doing good things in the north. The Borough Ward Declaration might be an issue, and the typical things are reaching out to communities that wouldn't come forward. But the fact I look at, you know, the ward that I represent, which is the lowest for cervical screening, I can imagine, you know, that number would be far, far higher, because plenty of people there would be doing it, you know, as you say, either their home GP when they're abroad or privately. I mean, is that something that we as a committee could write to West Streeting and ask the lead member?
I can completely hear everything Roberta's saying, but also I still think we need to question these things because I'm not taking any risks in any of this. But I think it's something, of course, why is that not happening? And would this be a totally different picture, and would we not be kind of reading this and
Pamela might wish to come in.
exactly why it's taken tens of years to happen? But I'm just going to bring you in before I go to.
Yes, and I think I completely take the view around the samples that are sent to the same lab, and I think that argument rightfully should be made. One of the reasons historically why the results have been approved from abroad especially, but from any other lab, is because of the quality assurance process that underpins screening programs nationally. So how would we quality assure the results that have come from another country where we're not assured of the quality, basically? And I think has been the principal argument. I do think it's a good idea to take this forward and to go completely to the top to ask those questions again, because things change over time. And it could be that there's been more collaboration between the NHS nationally and other countries. There might be a list. I'm not quite sure how that would work. But I just wanted to point out that there are quality issues that we need to consider when we accept results from other labs that we are not overseeing for screening specifically, and that we're not overseeing because they're out of the country.
Thank you. Roberta, do you want to say anything else?
Well, I mean, that obviously I'd assume most people in this borough would be on private rather than overseas. I mean, I'm sure there are people who do it overseas, but I'd have thought that's a much lower percentage in the privately. I guess my sort of comeback to that would be, well, then can we start looking at which countries would we accept? You know, are we going to, if we look at healthcare in France and Switzerland and other parts of Europe, you know, are we saying that the healthcare, you know, can we look at those healthcare systems there and say that we don't trust them? I appreciate that there's other countries perhaps that you know might not have the equivalent of an NHS or some sort of national health provider that you can say, well, we don't really trust that. But it seems to me, and particularly given how how European this borough is, if there are countries like, as I say, Switzerland, France, Germany, Spain, Italy, where I would have thought, I'd be surprised if the healthcare there was worse than it is here, that you can't trust those. I mean, is there a way of working it that way? In the same way that you have like a red orange and an amber and a green travel list, you could have a health list, the same thing.
And I think I completely agree, and that's the point I was making, that maybe that communication to national, whether to West Streeting or someone else, would be the way to go, because I work at regional level following these national guidelines. So although I could take it up that way, and we have several times discussed the possibility of accepting results from other places. So I think it would be a stronger voice coming from you as a council to the national team to actually ask those questions again.
I think as the borough, that there was even an article in my London today saying that we are the worst borough in the country. If we were to write to the West Streeting or senior level team saying, look, this is one of our suggestions, that we can have a better picture, but I think it would be it's coming from the borough that's being responded.
But also nice to focus our resource on what really could make a difference, which I think would be an absolute benefit.
If you go and you waste your time doing drop-offs in my ward, most people there have already done this, and it's totally unnecessary. And people who might need the help in those more deprived communities up north are missing out because of it. I mean,
I think
Can you just follow up on that, on there's loads of statistics in here and my brain hurt by the time I finished reading this report. But just on page 27, it's interesting, isn't it? And you find on there, page 27, where you get, it's like Brompton, Handstown and Royal Hospital are very, very high there. And you just wonder what they're doing that other wards that are lower are not doing, or that's just struck me as a strange report of that particular issue.
Yes, and so I don't think that, I think we have examined that and we talked to practices and we talked to the PCNs that cover those practices to see, is there a different offer that we can learn from? And there isn't. They're doing more or less the same things. And Naomi was talking, there is a universal offer over the whole of West London, which is offered for evenings and weekends with the LMA around screening too. So we try and address variation as much as we can. So we can, I mean, it's a presumption, I can't be absolutely sure, but it feels like it's a population issue and that there will be groups of families and things, of populations there that make the difference.
Can you get more on that?
Well, you might have younger, more transient families in certain places. People come, as you say, if they're American or European, they may well go home for their screening and then come back again. I can only presume it's that because the offer's the same.
Yeah.
But there is the World's End estate that is a much more deprived area. So people are less likely to be using private.
It was more the Brompton, Handstown and Royal Hospital that just struck me as interesting.
Yeah.
A question, I think to Susan about the new methods of testing. That I think there's still a lot of young women who rely on the NHS for the tests, and especially, I mean, these self-swabbing is quite interesting, and definitely, hopefully, we should see a difference on the breast front. Are we developing those new techniques whereby breast is not pushed on both sides anymore, but the pain is massively reduced with like those, well, sort of 360 degrees? Because from what I understand, pain is also, frankly, a barrier for a lot of women. The fact that we keep, postponing that test because it's a rather invasive and painful test, for the record, you're pressing the breast into. And so, the fact that we don't have to do that anymore in some more advanced techniques, do you think is going to be something we can invest? Or is it going to be part of this new procurement that
the new procurement will be mammograms delivered?
So it will be the old-fashioned
I think
mammogram?
we're very far from changing the imaging modality for breast screening.
Okay.
Ultimately, I suspect it will be a DNA screen, but we're we're not even remotely looking at a target for that.
Okay.
So it's the campaign.
Great. I just wanted to have that.
But I think just to note, because this is a recorded meeting, that pain is temporary. It doesn't leave after it falls down. So and the whole breast screening appointment is 6 minutes.
Yes.
So
Thank you. What you had?
Portia. Yeah, thank you, Chair. Could you turn to page 36? That page is showing medical centres have pushed up bowel cancer screening by 10.2% in the UK. And you're saying about engaging with patients, and I just wanted to know what focus is there on high-risk patients? Are patients proactively contacted by the GP if they are in high risk? What outreach is done to provide information about symptoms and testing? What outreach work is being done to find community advocates working in the community?
I didn't quite hear every bit of this, but we're looking at the data of the bowel screening, and are we proactively contacting patients post bowel screening DNAs? That aspect, sorry, I didn't hear very well.
So I'm asking you, the fact that Goldman is showing that there's a bowel cancer increase by 10.2%, and this is as a result of engaging with patients.
Oh yeah.
So what focus is there on high-risk patients? Are patients proactively being contacted by their GP So those who are an high risk, i.e. family.
I can tell you exactly what happened at Goulburn. They employed a physician's associate, actually the same one that was doing the smear tests, was proactively contacting every patient after they didn't attend and phoning them and discussing it with them, getting translators to do that if they didn't speak English as a first language. And she did a whole project specifically on this. So that is how Goulburn went up. I don't know whether she I can probably tell you she did not work on the high risk people, she just did everyone.
So what outreach has been done to provide information about symptoms and testing?
So she called everyone and had an at Goulburn, they called every single patient and they went through all their questions.
Yeah, I know.
And discussed the symptoms and discussed all of that. So she had a 10-minute consultation with each person.
No. I'm talking about, so this is what has been done in Goulburn. I'm talking about other GP practices now.
Okay.
What outreach has been done as a result of the improvement at Goulburn?
So the education around signs and symptoms is usually that's usually the national campaigns that we sign up to and agree with that. We've got some specific work working with practice websites and things where we try and highlight information and the risks that people should look out for. This information around what the specific that was done in Goulburn is something that we anticipate will be replicated around the PCNs once we start working in integrated neighbourhood teams, because there'll be targets that they'll be set that they will be encouraged to achieve. And these community champions that you described, there are various groups that we've had that we learned from Westminster, and we're now using here in Kensington and Chelsea. They've got slightly different names around exactly what they're doing, but they take up roles around advocates for the patient and exactly promoting the tests and signs and symptoms that they might look out for too. But we don't have a local education campaign around what to look out for particular
So
cancers.
the community champions, are they being paid?
They're in Westminster, aren't they? But we've got some here that are.
Yeah.
So all community champions are being
Not
paid,
all of
because there
them,
should be
not
an
all of them.
incentive for someone doing such a serious work that would give them motivation
So
to
the
carry
person
out
who did
precise
this,
work.
the person who did this was paid. But they were
Okay,
positions.
so it's not the community champions that were commissioned
No,
to
they've
work.
got completely different
Oh,
names.
okay. And what outreach work is being done now to find out community advocates working in the community?
So RM Partners is a strategic forum which is looking to understand and co-design interventions. One of the things we're expecting to do this year is a big programme on bowel screening, because we know men are less likely to have their screening than women. And there are different ethnicities that will have uptake, and that's where we'll be really co-designing the communications campaign and then working with and then doing some big large-scale advertising. As John said, we did some work with community champions where we essentially contracted people to phone, and what we did that for about 2 or 3 years, and I think there was some uptake, but there wasn't really a significant differential between them and the people that would have had it anyway. If we know the baseline's about 50%, we need to see a much bigger uptake. So I think that work needs to continue, and I don't think it's a one-off. I think it just needs to carry on with lots of different ways. I think practices still have their patient groups and often focus around bowel screening and all of the screening methodology.
Thank you.
So hopefully we're moving towards a system where every contact with a care professional you may well have a conversation about cancer screening in the same way when we see a child in a consultation, when we talk about immunisations and things as well. It's about making every contact a complete contact.
Let me ask you another quick question, because it's going to go back to the focus on those with high risk. For example, someone with, breast cancer in their family, and, they're not of that age to get screened, but then they demand it anyway. How often would the GP follow up on that sort of patient?
Should I take this available?
Yes, please.
Yeah. Just one other thing just to note about screening is we're expecting ultimately the NHS app, which has got about 32 million users, to actually send reminders and so on, which will make things a lot easier. So now looking at high risk patients. So the national screening programs are using age as the primary factor for risk. So they say you're more likely to get this cancer at this age, and therefore we'll screen this population. For the people that you're talking about, which are family history, for GI, there's something called Lynch syndrome, and people with strong family history that will be tested and will have surveillance colonoscopies at a period that's commensurate with their risk factors every however often that they need to happen. And that's actually not under the screening programme, that's under the local hospital that's managing them. And the reason is that for bowel screening, you start with a FIT test, but for these people, they'll all have colonoscopy. So that's that population. For people with a family history of breast cancer, similarly, if they have a strong family risk, they will have the genetic screening, and based on that, a surveillance amount will be agreed. In the breast screening programme, if you are very high risk, you will sit within the breast screening programme, but other risk factors are managed locally. And then for cervical screening, if you have any abnormal cells, then you will be managed locally, because all of the screening programmes have a big prevention arm to ensure that prevention happens. And just for completeness, for the lung screening programme, we often now, because of the amount of imaging we do, find lung nodules, not, when we were doing a completely different test. And so those patients also have surveillance as well. So there's a lot more surveillance in people before they ever got cancer because of family risk, as you're saying, but they're managed not through the national screening programmes.
And that is ruled out in all GP surgery.
It's not down to the GP surgery. It will tend to be that the primary index, so the person that had the cancer, their families will get tested and then they will be managed there. So the GP often has less to do with those patients.
They do the original referral. Someone comes and says, my mother's had breast cancer, and then we do the referral, and then they sit within that service so that there's no slipping between the net.
One of the things that we're hoping will come out in the new long-term plan and cancer plan is better systemic identification of people with genetic risk, because some of this is very historical.
Thank you.
Thank you. Well, I appreciate you.
Yeah, it's a couple of quick points. I don't want to labour the issue of the data, because I know we've already, it's been brought up and we spent quite a bit of time talking about when we were thinking about vaccination rates as well, which are extremely low and possibly for similar reasons. But I guess the question I have is there a way, I'm not a statistician or anything, but is there a way to kind of control for these factors, or to have a kind of an estimate of what the uptake should be if we were to filter out those people who are, under private healthcare, for example? The abroad question is maybe trickier, but certainly from the point of view of private healthcare, we should be able to have estimates as to, controlling for these factors, because at the moment the main question that I still have is, where is the unmet need? What is the unmet need? How do we quantify it? Who is it impacting? And I think I'd just be a little bit wary about being quick to explain things away with that. I know you yourselves, you haven't necessarily, but I'm just thinking about the way in which there are changes over the years, sort of ups and downs, certainly from the point of view of cervical screening, which, I mean, how do we explain, sudden drops like this, or improvements, if it's not kind of lined up with, a sudden exodus of people, or a sudden popularity of private healthcare, which, I'm sure is a factor. So yeah, just like what is the unmet need, and in 5 years' time, if these initiatives are going to be successful, what would we expect the numbers to look like? That's my first question.
Sure. So I guess we can't control it particularly well, and the reason is that this is one of the richest boroughs in the entire country. So there's not other ones that this is the sort of site where this is such a different problem. And so because we don't control it, we can't make assumptions.
I'm not asking sort of about benchmarking with other
No,
boroughs
there's
or areas.
no methodology, because we can't see the data to do that. So what we, and so I think what we are doing is assuming that people haven't had that and continuing to make sure there's access to everyone. I think in areas, as Naomi and Andrew mentioned, of deprivation, we pretty much know they're probably not going abroad and they're not going privately for these things. So that's where I think we could say those numbers are likely to have less factors in. But what those populations, if you look at Earl's Court, that's a very, very high mobility population. And that isn't an up and down every year, that is a stable churn.
So there's no way to kind of estimate how many people are registered with private healthcare providers in the borough.
But we could call Bupa and do a Freedom of Information Act and ask how many people in the borough of Kensington Chelsea are with Bupa, how many people are with ACTS PPP, how many people with Cigna. You know, there are only so many we could. We've never done it, but we could ask, I assume, for an FOI on that. But I think it's going to be quite high, and it might make a huge difference.
Yeah.
And then you work out the women and. You know, if we had done that, then that probably would have been helpful at this point. But that would be the most sensible thing to do, just listening to this conversation.
Yeah, even if they're registered, doesn't mean to say they go without those tests. I mean, they may register for the hip operation or the.
But a lot of women would prefer to go privately for the reason that because most of the screening tests for women are uncomfortable rather than painful.
Yeah.
And so, is that fair?
Yeah, I agree with that. I agree with that statement.
And if we link it to immunisation, which Councillor did, we did get some input from NHS England this year looking at private vaccinations of IMS in our children. And what we did see, and this is something we always suspected was happening, and what they were able to do was come along quite independently and evidence that in a way that we couldn't do before. So I think it's a good point. We can do it, maybe not by going to the insurance companies, but there are pieces of work that people could do maybe to try and quantify those numbers.
Thank you. I just had a quick question about the self-screening as well. And sort of, I don't know very much about it, but my understanding is that it does have quite high rates of false negatives that need that mean that people need to have it repeated or followed up, or is that not the case anymore?
So because obviously the main issue is that it's very difficult to swab your own cervix, and so it's a slightly different swab. You're not sort of going as high as you would if you were having a cervical swab. The way that we're approaching self-screening is that it will be for people that haven't had anything else. So if they're DNA, then this is the way that we at least get them participating. The way they do.
So the self-screening will only be offered to people who
have not participated.
Okay.
Yeah, and that's because it won't have the same QA as somebody that's been trained to be a smear provider with 30 watched, etc., etc.
What's the QA, sorry?
The quality assurance. So there's to be allowed to take smears, there's quite a lot of training and watching to be allowed to do it to make sure that the QA is very strong.
So I'm not following. So it sounds like it's quite a tricky process to do this.
So the self-swabbing is just an internal, you swab yourself, and obviously that won't be the same as if you've been a qualified smear provider. But if people aren't participating at all, the self-screening has been shown to be helpful in getting people into the programme and identifying HPV, which is the virus that we're looking for, which causes cervical cancer.
So the negative issue that's been sort of raised with these testing, these tests in the past, especially where people don't kind of get enough of a sample.
It does bring it. We're about to start a diagnostic tampon at one of the practices. It's going through all the quality assurances and hygiene things that need to be done for this to be a pilot at the moment. So I think probably in 6 months' time I'll be able to give you much more information. But if you have a negative, if you have a positive on it, then you are more likely to come back in and have a proper smear because you've got positive. The advantage of it also is that it is more appropriate for the unmarried lady.
The positives are obviously much more straightforward. I'm just thinking about the fact that people might be falsely reassured with negative tests, because I think that has been an issue that's been reported with the self-swabbing.
Yeah, but I think the target of people we're going to be doing it with is very specific at the moment. So we're only rolling it out essentially to certain populations at the moment.
And I might just bring in Pamela here. Pamela, the self-swabbing for cervical that NHS England's rolling out, I think that's been well tested in terms of sensitivity, hasn't it?
I think it has, and I'm not sure I know about the high false negative rates. I think there's something around the instruction that goes out with it. And I know that colleagues have been in touch with other countries that have rolled this out, for instance, in Australia, and taken from them information about how to reduce those false negative rates. So there has been a lot of work done to ensure that we are getting the more positive results, or at least getting more uptake from implementing this. So that's my understanding at this point.
Just finally, I just wanted to pick up on Portia's point, because if that's okay, because obviously the deprivation gradient isn't applying here, which is quite striking from the point of view of social deprivation and income. But where the disparity does happen is around race and ethnicity more so than anything else, especially for cervical. And I was just wondering about the scope for culturally competent health advocates and the use of the voluntary and I don't know, not faith, but the social enterprise and voluntary care stuff work, if that's been thought about, or any examples of it working well elsewhere. Through the community connectors or something else.
Yeah, absolutely. And can I invite my colleague Liz Dunsford to come to the table and just say a few words about this? Liz is our screening lead in the Public Health Directorate.
Oh, thanks. Yeah. So there's been a couple of programs running to do specifically that. There was a very large program called Screen, Detect, Protect, which you should have some information in here about. And that was funding and training third sector organisations, particularly from the Black and minority ethnic communities, but also looking at homeless, looking at those people with long-term mental health conditions, because all of those groups got lower screening uptake. Yes, that was a very large programme. I can't remember the numbers off the top of my head, but that reached thousands of people within Kensington and Chelsea and Westminster. So that ran for a sort of year and a half. And currently I've been training all the community champions as well. So they're all a lot more up to speed on outreach and promoting cancer screening. And we're also going to be funding some more organisations to kind of work in this space as well. So, and there's lots of learning and lots of resources that were created by local people, which are sort of very niche and kind of address, for example, say those from who've maybe had an FGM experience, or those who've had sort of sexual violence or whatever it is. And there was lots of very tailored resources were created. Some by community champions programs who were particularly funded and by others as well. So we've got lots of learning in this space. And I just think what's really important is that we continue to train and support those organisations who are very willing to do the work, but we need the expertise from, say, the breast screening service, the bowel screening service. There are two great health promoters at the moment, but then we share them across all of sort of northwest London, and we need some sort of additional support on the cervical screening side as well, rather than just being me doing it, and just try to just keep up that training, finding those third sector organisations, doing the training, and then letting them feel they have the confidence to kind of have those conversations and kind of engage people in this whole area. And it's I call it's a war, not a battle. All right, it's not something you're going to do 1 year and it's going to be a done deal. We have, as we've all spoken about, populations that change a lot, lots of turnover, new people all the time experiencing our health system, and people kind of worried about health systems or whatever it is, and we just have to keep going.
and be very persistent about it over a lot of years. And that's why I think it's really important that everybody kind of buys into.
Just
Very agree.
it's more really a comment about the just about staffing capacity, nurses in particular, because the report does mention that we have the lowest number of substantive nurses in North West London, and to what extent you felt that had an impact on the figures, if at all.
I don't, because we've got, we appreciate it's difficult. We are training up more nurses because people are coming through our systems. They're going through becoming nurse associates, becoming nurses, becoming practice nurses, is all within primary care. So we are trying that. I'm not sure whether that is it, because we have employed physicians associates and trying to get them to do both chartered IMS and SLA tests. So I'm not convinced that that's it, but obviously the nurses do call patients if they don't do bowel screening. So, not having them would need someone else to do that. The other thing I just want to mention, and this is very anecdotal, etc., but one of the social prescribers in our locality, actually the lead for the North, has been diagnosed with breast cancer based on a mammogram. And somehow our lots of patients have been calling and said, I heard from this because another social prescriber, and they deal with most of the deprived populations, social prescribers, they are really pushing for people to have mammograms based on just one person being diagnosed within the team. And that does make a difference. And when we're talking about community workers, that's what social prescribers really are.
I don't really have any more questions to ask. I mean, we've had a really good discussion, and really the thing that I'm interested in is the VCS, and particularly because I think it makes a difference in North Kensington. I've been to one of these workshops quite accidentally. I just happened to be in a community centre and there was one going on, so I know how it works. And you've got some figures in here about awareness, which, it's 90% of participants say they understand more, but do you have figures on how it actually leads to more testing? I mean, it's probably quite hard to do that. I guess my only other point about it is, how do you scale it? It's expensive, right? Actually, I was impressed to see that you've got 16 of them that are involved in this, 16 VCS organisations, most of which will be in the North. But how do you scale it? How do you make it? How do you learn from it and get more of it? Because I think it's just very expensive. It probably works.
What's coming on that list? I think it's a challenge that the system has to put sufficient, as I say, manpower with respect to the kind of the experienced health promoters who can do the training, and we need that commitment from the system that those people will be there to do it, and are sort of going to be there over the next few years, and some resource as well, and that's sort of supposed to be both from whether it's going to come from NHS England or wherever it's going to come from, that's commitment needs to be there. So kind of keep funding and keep pushing and making sure we have enough to do work at scale, rather than just sort of fiddling around the edges.
And then, do you have any kind of data that really shows how it makes an impact? Yeah.
So the Healthy Communities Funds that we've just started the rollout of in Kensington and Chelsea, we're currently seeking an evaluation partner to work with us alongside that. What we're really looking to do is the organisations we commission and that we work with, we're looking to change the referral data so we can really get more of a picture of referrals that are coming in from the NHS, so why up from the voluntary sector. So when people come in for a screen, or when they come in to be immunised, or when they come in for another service, that question is asked. So what we want to be able to do is get some idea, is it something a community champion said? Is it because you attended a session in a voluntary sector organisation? Is it because of one of the other community initiatives? So it's really important we build up that evidence base. It's very much kind of an emerging evidence base. Intuitively, we know that community leaders play a very strong role in behaviour. and in behaviour change. There is various pieces of evidence that point us in that direction. Learning locally, we're learning from basically national best practice elsewhere, international practice in some cases, in terms of some of the connector roles, and then we're really looking to model what happens locally. But it's very much a local evaluation versus randomised control trials.
It just helps obviously to let the story children ongoing to me, so the more I with you, the better.
I'm going to ask a quick question. Yes.
Okay. Just really following that, just faith community as well are often a useful place to disseminate information. We have a very strong faith community networking and just to flip it the other side, we've talked about some very granular stuff. I just wonder whether we're making enough use of public awareness campaigns. You know, you look at those really great campaigns that have gone over the years, and if this is really an issue, are we doing enough big public awareness campaigns?
I don't know if Pamela wants to come in on this. So there are some of the national campaigns that have been rolled out at the moment. So the current breast screening one that is getting quite a lot of airtime on, you know, TikTok and kind of Facebook and other places. It's the one where when I get home, the first thing I do is kind of take off my bra, that one. So there's a lot of kind of national campaigns which we're looking to learn from. And a lot of work and research goes into those national campaigns. So the behaviour change units kind of within the national teams have worked to develop these campaigns. And what we really look to do locally is to join up with those national campaigns and to work really to disseminate them as much as we can locally.
Do you want to add to that too, in terms of the recent changes within the are we worried about sort of ICB funding for those types of campaigns, and is that going to affect what journalists is talking about, or sort of more local approaches to comms in terms of cancer screening?
So those national campaigns wouldn't be funded at ICB level.
Yeah.
They're funded basically much more at regional level, at national level. The concerns around ICB, I think it's very much around capacity and resource locally. I think perhaps Andrew would like to come in and a little bit about where you are with the ICS reorganisation and what we have now might look like, or it's very difficult to place, I know, but
Thank you. That's awesome. I don't. You really don't know. We're putting in an operating plan, I think, before the end of May, and I think we will share your anxiety, but we have assurance that actually this whole process is about taking money from one part of the NHS and putting it into the very parts that you want to invest in, and we can trust our bosses to do that. Then that's what we'll have, I'm sure.
I just really say those national campaigns are great, but if we've identified a more local problem, how we tailor some of those campaigns to a more local messaging.
And we have done it at various levels. So again, probably we've used Dr. Katz in the past, but we often work with local GPs, particularly local GPs who speak languages which are common within our communities. And sometimes we find those little videos with local GPs very effective. Local communities tell us sometimes rather than written information, the kind of the digital videos are quite an acceptable form, and they tend to get kind of passed around quite easily. So we've really developed our work in that space, and there's more that we can do.
Just going to bring in Heather. You had a hand.
Yeah, just to add to that, thanks about the national campaigns, with an example of the recent breast screening campaign that's just been mentioned. Although it was a national campaign, there was what was termed an uplift section to that, which was specific to the London region. So that used things like community radio, using community centres, and targeting some local population groups as well, using social media with AI, I would imagine, to target those populations. So in a lot of the cases when there's a national campaign, there tends to be some uplift, something done differently in London to target specific populations, because we've seen the data. London as a whole tends to be quite low when it comes to coverage compared to the rest of the country. And then just to add to that, in terms of the recent news and the reorganisations and all the changes nationally, prior to these announcements, the plan was always to delegate the commissioning of most of the screening programs to the ICBs. And until we are told otherwise, that's the plan that we are working towards. We're working with ICB colleagues in terms of how we work together. But despite what that would look like, I think the emphasis is still around a collaboration to ensure that we're doing the best we can to pull our resources together in terms of improving coverage across London.
And one.
Just to finish off, Dr. Captain mentioned reaching out to the insurance companies, and Dr. Stephen, you talking about other methods of doing it. Is that a commitment from you both?
No, I just came up with that because it just makes sense, but you know, I'm sure we can
Who would
find
need to
somebody
be,
to
again, who would need to do it?
So that it was London NHSE that raised questions about our immunisation numbers, and then we told them our story, and they then tried to come and evidence it, and were able to evidence it. I think you would need a similar independent.
And we did
You
an
can go to
audit,
London
we did an
NHSE.
audit last year on vaccinations.
Is that you asking about an FOI? Sorry,
Was that Dr. Captain mentioned? I mean, well, then could we get the London if Pamela with
We
Dr.
can ask our team what we can do.
Yeah.
We can ask our team, we can't guarantee that we'll get an FOI, but we can ask.
Yeah, all those other events that you mentioned, it'd be great to get an update, say maybe in 6 months.
Just going to see if anyone in the public wants to ask.
Just very briefly, just to respond in terms of why some of the residents access healthcare outside the country. I come from France. My mom died of colon cancer. And I got a call from my GP, my family doctor in France, saying that you've got to do that screening. All my siblings had to have it. I went to see my GP. GP said to me, no, in this country, we don't do it until you are 50. So I think there's a big issue in terms of tailoring screening, because as you were chatting, I looked at my NHS no reply text. It's all about enhanced health check. There's nothing about the history and what I could be prone to develop in the future. So that was just that point in terms of why, if you have the luxury of having healthcare in another country, you go there. Is that we don't see prevention is different here, and it's because of national policy and not necessarily what is needed for an individual, especially if you have a history of certain conditioning in families. And just in terms of screening, that's great to have community champions. But I would say, why don't you invest in a mobile screening unit? Because when you have an event and you've got 800 people attending, you can give them information, but we know study shows that giving people information doesn't mean that they will go and get the screening. But if you give them the information and screening is there, they'll take up that screening. So it may be worth investing in. Yeah.
I agree.
Any other further questions? Mary?
I'd just like to make a positive comment. I've just seen the bowel screening kit that's come out, and I just wanted to congratulate whoever's concerned for the language used in it. Because one of the things is that when these kits go out, you have to be able to understand what you're being asked to do, because it is quite complex, which there's no doubt, well, there's a compliance issue. But the language I thought was judged just right, and the tone was just right. And I think that's really difficult to do. And so congratulations to whoever did that.
I'm afraid that none of those people are in this room.
Make your challenge.
Thank you all so much for coming. I think in terms of what would be interesting would be to explore what the purpose is expanding, what we can do together, and migrate to an understanding of this data, so we cannot be sort of perceived firstly as the worst borough in the country. And I appreciate what Roberta was saying about earlier, we need to ask the questions, and it's whether that's also us as a committee in terms of this being deemed as the worst performing of these at the moment, to write to government, ask us treating is the new health secretary to consider really escalating this, so that we can have a better understanding of. I would be very keen in the committee to do that, because I think from us as sort of performing very badly, it might actually
We're the best in London.
But I really appreciate you on tonight, and it was a lovely evening to sacrifice to sitting indoors.
Thank you very much.
Moving on to agenda item 5, supported accommodation for older people. This report also extends on specialist accommodation to older people, which forms part of the council prevention strategy and approach to meeting in its care duty. The committee is asked to note the reports and share any questions about specialist accommodation provisions available for older people and consider how to ensure people attending. We have Councillor Bishop Brendel, our lead member, Shadia Ghani, head of care market, and Sharon Burby, interim head of care design.
I can start, Chair. Thank you for this. And unlike the last paper, which was obviously solely NHS focused, this is the one which is definitely in the purview of the council to work on. And this is specialist accommodation for older people. Now, we provide specialist accommodation for a wider range of people, especially people with learning disabilities, people's mental health needs, but this is specifically focused on people who are older who perhaps need extra support. Now, the council kind of commissions many accommodation providers right around the borough to help with this. As you'll see in section 5, we lay out the different versions of accommodation. There is sheltered accommodation, extra care, nursing care, etc. But the report focuses mostly on extra care, for example, and care homes in itself. So across the borough and those two issues, those two concerns, many of them are private health providers. So we don't actually commission services from them or provide residents to live in them because they're just too expensive for a public organisation like us to afford. So people go on there privately and they can do that. And there's one just down here called Loveday. Separately for extra care, we will provide service and commission service for that. And as you can see that in the front part. So we've got James Hill House, which is in Bolton. Likewise with Burgess Field. Miranda House, I think, is in Councillor Petit's ward. And Lots Road, which the council is working on to commission 65 new care homes. And we're working with partners in Mount Mantle, who are developer, to work on that. And I know Councillor Hargreaves has been working on that, especially that is in his ward. So that will hopefully relieve some of the pressure as well when Lots Road comes online, hopefully in the next few years. And we also focus on demographics. Obviously, we're getting the population is aging. I think for us, we're particularly acute that aging is more in this borough. So with the recent census data, you would have seen that the borough's had a slight decline of population. It was done over COVID, so there was an argument that we're not sure about the true figures really, but our population is getting older as well, and more people with more long-term health conditions, which I won't repeat what's not, but more long-term health conditions, which kind of exacerbates that, and obviously more people come to the council in order to get support. So as you can see, it's kind of wide-ranging. As I said, really committed to maintaining people as locally as possible. But yeah, happy to take questions on that with my two colleagues here.
I am going to actually start with Anne.
Thank you, Councillor Randall. I guess when I had sort of thoughts and questions about the Lots Road and the extra scheme that we've got there.
Yep.
And I guess my first question is, I mean, it's great news, it's really good that we're doing it, but it is 65 units. So
yes.
It feels like a little bit like a drop in the ocean. But I think in my experience, what happens is that everybody wants these units and everybody thinks that they've got a better case than anybody else to have them. How are we going to assess who is actually going to be eligible and gets priority for these units? And how are we going to explain that to people who don't get them, which there'll be a lot? And I guess my worry is we put in all this investment and do something really great, but actually it ends up being negative because people don't get them and they feel like they should have got them. Yeah, so what's the assessment?
So I'll let that change.
And actually I have another question about this as well, which is maybe for Councillor Wheel, which is how do we keep our property department to account to actually deliver this stuff by 2009? Because
19, 29.
Sorry, 2029. Call me a cynic, but you know, we've had a lot of these where things are meant to happen, they don't happen, and you know, I'm not saying it should come back here. It's a OSC thing, but how are we going to make sure that these things actually happen and know when they don't, when they're not on track to happen?
I'll take your first question, Councillor, and slightly part of the first one as well. I'll let Sharon Shadi come about the specifics. Who does it? So I'm working with officers here, especially Gareth, who's our Director of Commissioning. I've asked the question, especially in the first part, about 65 as a drop in the union. And I have pushed and asked to say, look, is 65 the right number? Could it be potentially more, considering that the council land was developing the site ourselves? I think, and the advice go back, which is pretty strong, is that the more potentially homes you put in, like, because, for example, a question was raised, can we go from 65 to 80, for example? But with that, with too many people, it actually doesn't become quite economically viable. And secondly, there's too much pressure on the staff and everything else to look after that many people, which actually has a detrimental impact in the long term. So 65 is probably the best maximum we can get for what that is. On the second point about ensuring these are done on time, that is an absolute concern of mine. I must admit, I agree. It's currently, as the OSC would have seen, Lots Road is currently an amber rating on the RAG rating risk register recently. But obviously, some of it's out of our hands as well, because we work with a third party on it. Obviously, there's further consultation. There's issues with Lots Road specifically. It's halfway in Hammersmith and Fulham, halfway in RBKC. Both have different planning policies. Both have claims over who gets the majority of 65 care. So all this stuff we're still working on at the moment. It's my hope and my expectation that this will be completed on time, and we're currently on track with that. But it's certainly something that comes up every single one of my briefings. We follow all of our kind of capital building works. Lots Road is kind of one. The other one's Kingsbridge in North Kent. We've got a few others which I've mentioned here before, but won't go into them now about that as well. So yeah, just kind of ensuring that does happen. But there are challenges with that. I admit that, and I don't want to mislead anyone to say that. But yeah, that is certainly the case. But I'm not sure either of you want to cover about who can actually access these things.
Yeah, the first question about how are you going to assess people fairly and have it be seen to be found.
So it can pick up on the assessment, it can pick up on the number of 65. So
we brought 65, and I completely see there's a point where it just becomes too many. But I just want to make sure that it's fair and that people see that it's a fair process in terms of who gets them.
So in terms of the assessment process, so these will be for adult social care clients. And so there will be a Care Act assessment undertaken by social workers. And of course, there might be a number of different residents with different needs. And so there's a panel as well. And so there's an extra care panel that look at all the new referrals coming through to make sure that the person with the most need is the person who's placed first. So that's already in existence. So we already have 3 schemes in our BKC. And so there's already that process of residents being assessed for their need, understanding there's extra care and appropriate setting of care. Will it suit their need? Is it what they desire? And from that, assessment is made, yes, it's the right thing. The panel will say, actually, this person's need is the most pressing, and that's the person first in hierarchy. And so that's how it works. It's based on an adult social care Act assessment, Care Act eligible, and it works through that.
And what happens if somebody's not happy with that?
The person can, they can escalate and say, I'm not happy with my assessment. To date, we've not had that challenge. And of course, we're actually opening up. There's going to be, a significant increase. We have currently 76, and so 65 is going to be a very significant increase to that. So we're not
reassuring. That's reassuring. Thank you. It's really reassuring.
Can I just add to that? I guess this is almost doubling that sort of quota here, which is fantastic. There's also
a huge sort of campaign around raising awareness around what each of these schemes mean and what they deliver, because sometimes it can be confusing. What's the difference between nursing, extra care? What does it mean? How many hours do it get? So some of that is around communicating what the difference is to those and making sure people are very aware of what that means around the support and care, and ensuring it meets what people need when they get there. So there's ample time to sort of build on this for the new project, but also building on, we have these services, we're resilient in knowing how to do some of this work with our social work teams as well. So that's something positive to build on with that. Yeah. Portia,
Yeah, thank you, Claire. I'm on page 75. Which shows the over 85 population grow by 33% by 2030. So what is the planning for the financial pressures this will put on social care? Have you got any questions for that? And 5.19, the number of people aged over 90 will double by 2040. Will there be enough specialist care home places?
Thank you. Sorry, Portia.
Are you going to remember all this, Josh?
Well, one's on money, one's on extra positional places. So I'm still.
And also 5.21, which is RBKC is very independent. Yeah, on the out of borough placement for older people. So how can we create more in borough provisions?
So I'll take the first one first, and then I'll talk about it. So really good point about funding. So every year in the ASC budget, we do have we put in a growth bid of £500,000 every year to ensure that the demographic change is reflected in the budget for this portfolio. And we try to mitigate that as much as possible. Of course, the challenge is that not only the funding comes from us, but comes from the wider element of NHS as well. So we have got a 50% cut this year in our Better Care Fund, which the NHS gives the council, all councils, but everyone's got a 50% cut. We've got a 50% cut, which is about £1 million effectively, which we need to find for next year, because that's going to be, we're £1 million short already, and we haven't got the money for that. Because as you know, council budgets are really, really tight. So it is really, really tough. I got to say, I'm not going to beat around the bush, but we need to have proper system in place to get this, because this is a statutory responsibility for the council to do. So it looks like we will have to, like, when we get to budget setting next year and over the years going forward, kind of really scrutinize what the best spend is in other parts in order to ensure that people here get the care they deserve as well. So we tried, as I said, we tried to do our best year on year, about 500,000, but it's going to be pressure, and we do work on that. But I can't give an answer right now to say, oh, we're definitely going to be completely funded in 5 years' time, because I just don't know. And that's the challenge that we're under politically as well. And you know, I've gone back to the ICB many times since the funding cut. Actually, we're appealing the decision to cut our funding by 50% to ensure that things like this, you know, don't happen, because it really puts pressure on everyone. Secondly, on the out of care, out of borough care, I don't know, you got a second one in the middle there. Yeah, so that, I mean, we do have to send people out of borough. That is just reality. They're in a small borough, as you know, very expensive, as you know, in most parts. So we do have to send them out, but we do try to make plans as much as possible. I mean, as Sharon said before, the 65 coming in 4 lots road will actually have a big boost to overall capacity, basically doubling what we've got right now. But obviously, that's not going to mean that that's going to solve all problems for the rest of the time. And we'll still need to look at overall what we can do. We need to do best for us.
Yeah, I'm very happy to pick up. So happy to pick up on the cost out of borough, and you had a third point as well.
The third or the second?
The second point.
The second was the number of people aged over 90 by 2040. So will there be enough specialist care home places?
Okay, so in terms of
We start with the costs, which Josh picked up on. He talked about the growth planning, which I'm sure you're familiar with. These are projections. And so projections always come with some caveats as well. One of the main things which you'll, in many of these areas, that you'll talk about the prevention agenda, because, you know, there's an assumption that with age, that there will be ill health or be demand on the system. But if there's any breakthrough in any of the dementia drugs, if there's any breakthrough in any of the technology, things start to shift. So there's lots of variables which may impact on demand and demand for specialist accommodation. The other thing which RBKC is incredibly strong at is the older people day opportunities. There's really strong offer here, and that again is about preventing the need for specialist accommodation, supporting people in the communities, working with third parties, working with the voluntary community sector. It's incredibly strong in this borough. And so making sure people are maximising that. We have a prevention strategy, which is just about to be launched. Again, enabling people and empowering individuals to look after their health, to reduce dependency upon the system. And in terms of, we talked about the growth, so we do have this really exciting opportunity for the new extra care, and it is super exciting. We're very excited about that. That doesn't detract that we do have out of borough. You know, Josh highlighted it is a small borough. There are costs, there are land issues, but we work in terms of often people will want to live closer to relatives that may not necessarily live in borough. It is some people. You know, we do have to depend on out of borough placements, but we also have quality assurance systems in place to make sure that really works for us, including a dedicated residential placement management team to make sure they're right for people, to make sure people are living well. We have a quality assurance team, we have monitoring offers. And we continue to work, and we work in partnership with housing, with planning, in terms of looking at long-term commissioning arrangements, looking at what the changes in population, what the needs are, how things are changing. And Josh highlighted that there are changes in the ICP funding. What does that mean? What do we need to think about in terms of our commissioning process? So all of this is in terms of looking at putting it together, that commissioning intention, to make sure that as the figures are coming through, as we're looking at things, you know, if the projections show up into reality, that there are services in place to meet those needs.
So, so you are gonna so how are we gonna create more in-borough provisions? That was one of my questions. You spoke about alternative or actually improving service provisions, but I want to know how can we create a more in-borough provision?
I think we need to explore what the options are and what the needs are, because, you know, it is an expensive borough. There are very limited land opportunities, and what are the actual needs, and actually, you know, what's cost benefits? Because if you have a very expensive in-borough offer, does that limit the actual total number of options? And so there is a piece of further analysis as to what options need to be. So an in-borough offer would be utilised, but we need to make sure it's cost effective. We also need to make sure it's right. You know, we do have high noise levels, we do have high air issues. They're not challenges experienced by everywhere. And so, you know, we need to explore what options are on the table to make sure that there's an appropriate investment. And at the moment, that's still being explored. And so any decision around in-borough, out of borough, you know, that needs to be well informed, well thought through, with everybody kind of cited as to what those options are. And we're at that exploring place, at that looking at things, looking at the intelligence, looking at the data to take that forward.
Thank you.
Okay, sorry, I was going to say we are doing that with some of our providers and the wider marketplace already as well. So we talk to our existing providers and wider through notices to ask around when people have an asset that we may be able to purchase or spot purchase or look to develop as well, along with our housing aids that Sharon mentioned. Because part of our market position statement, which is a document we're sort of ready to put out, also talks about our demography and need, and asks that question, who can help us to deliver this? How can we work together to support the developments that are needed as well? So we do that as part of our commissioning piece of work and our sort of market management, and trying to understand the intelligence, what resource we have out there as well. We've got very good relationships with West London Alliance also, who have a range of accommodation that we can link into. So it's not just about looking what's within the borough. I think we have to be pragmatic and realistic and think what else is there out and about in borders. Where else do people want to live? Not everyone wants to stay in the borough, Sharon mentioned as well. So we try and capture all of that to help sort of harness what we can utilise really. Jackie.
Yeah, actually, I was planning to ask that question earlier on, and I'm going to play the devil advocate of Portia. I'm slightly confused by this obsession that we seem to have developed to stay in the borough. We visited Ellesmere House, and it was a remarkable facility, but it was an extremely congested area of Chelsea. None of the patients could actually go outside because a lot of them suffer from dementia. The visiting rate of families is pretty low. I actually specifically asked that question 3 times. And don't get me wrong, it was a remarkable place, and I was very inspired by the dedication of the staff. They were highly trained, highly qualified. But I just felt that could have been somewhere else, if I'm being honest, perhaps less congested, less polluted, probably less expensive in terms of real estate, and also less expensive to work for the staff there who had long commute, some of them, when you started talking to them. And so my personal view is very much, we live in a very small borough. We don't offer a lot of green space. Real estate is incredibly expensive. There is no data, I could find that link family visits to location, because it is also an incredibly international borough. People travel, they're very mobile. And for instance, my family doesn't live where I live, my parents. And so I do not expect to live where my children are going to form their families necessarily. And so I do think we need to be far more open-minded. And there are some really lovely green spaces not so far away from our borough who could actually welcome in extraordinary conditions with the right level of training. And for me, I think the quality should surpass the location. And if there is no stronger position and no real data showing that has a detrimental effect, I'm very much open to look at other options where we can actually offer proper care. And I'd rather see that than a long waiting list, frankly, of people declining faster at home.
I think you raise a good point. I would say, though, that care in those places like that are good as it is, and CQC report on that. Ellesmere, I know for you, it's next to the hospital.
Yeah.
It's next on Fulham Road.
Yeah.
Very busy. But at the same time, it does have its own outdoor space and outdoor courtyard where people who are suffering from a form of dementia or Alzheimer's or have a physical disability can still enjoy outside space. And the garden of Ellesmere is quite nice, actually, for what it is. But I think we need to offer services here as well, because people, like you've mentioned, live here and then they want to stay here, even if their family don't live here, and people just want to be in an area they feel comfortable. And I've met numerous residents from Ellesmere, actually, who have lived in the borough their whole life, like north or south, but they just want to stay in the area, even though their children may live somewhere in the world.
I completely understand that, Josh.
But are you saying perhaps, if we were to commission a service of a care home, let's say, with countryside around it, you can find it in Surrey now, to put people in, is that something that we should be exploring? That's what you're kind of saying.
Yeah, I was thinking, I think we need to be quite open-minded, because we have that sort of preconception that we're going to really ship our old people away from us, which is obviously not a very appealing picture. Nobody wants to be treating their parents like that, nor do they want to be treated when it comes to their age line. But I just think we just need to reshuffle the narrative, because this might not be what we're doing. And frankly, what I read from the report is also that we are trying to keep people inside their personal space, inside their home, as much as we can, which is naturally in the borough by definition. And I really support that. And I think we have strong data to show that we keep them mobile and agile mentally longer when they stay in the familiarity of their house. But when we reach the actual point where people are, either need extra care or suffer from dementia or Alzheimer, and the ability to judge their parameters around them, including their own family members, I think there is an argument to say, well, there could be, if there is no opposition and it doesn't have an impact about how they're going to develop, meaning are they going to miss out on visits or care, then definitely why are we resisting it, apart from just we're not getting used to it?
I think just, unfortunately, I think I know what you're going to say, but just to add to this, I think there's two strategies. There are people who want to stay close to home. There are people who, they reach an age and they see they get older, they might want to move by the sea or be somewhere different, and it's kind of understanding what options we have and giving as much of a choice as we can to residents, which I think is everything Josh is trying to say too.
I just want to say, we also, I can give you quite a few examples of our own elders moving outside of the borough. Their health deteriorated like within a month or two. They don't get no visitors and they're dying slowly. Whereas if they were in the borough, they'll get 10 visitors a day or 10 a week. But I understand people want different things. It depends on, but I think that it's in our best interest to try and find resources.
I think you're both right in a way. It depends obviously on the individual. So we get a lot of pressure, not necessarily on older people. We get a lot of pressure from people with learning disabilities who want to be based in the borough, and they say, if we have to put them somewhere else. Some people go as far as Scotland. I mean, and for some people that is not their, obviously they're getting care and attention they need, but in terms of their community support, obviously that's not there anymore. And people want to be in the borough because they get, they grew up here, or even if they may not have family here, they have friends, or they have some kind of connection which they can connect to. But also at the same time, like you said, Stephanie, that may not suit everyone, and they may want to move closer to family. So it is a real tough balance. We don't have all the answers for that, and we can't commission everywhere on anything. Just on the basis of like, I feel like the sea, I feel like the mountains, or I feel like Wales, or it's just unfortunately we have what we have, and we provide it when we have it. I think is the best way to put it.
I think, and there is the want to have that balance too. Obviously, it's about looking at people's care and support needs. So looking at somewhere in borough, which if people need an open space or they need a particular environment, that will be part of that assessment of their need. And it would maybe deemed that actually a vacancy in borough wouldn't meet their need, it wouldn't be conducive for their good health. And then teams would look wider and further afield. Sometimes people aren't able to make a decision, so a best interest decision is taken with all of that information on board as well. And often families are involved in that, so even though they may now visit, they may want them near, so it's a real challenge of balancing some of that, isn't it? But definitely some of the work we're doing with providers of housing and other has to be looking beyond our walls here, because if that's how we're going to meet needs and also meet people's wishes too. Some people want to be out of borough, but that connection in is always also around where is their support mechanism, where have they had healthcare, where have they networks. So trying to keep that interconnected is very much part of the care act, so keeping people local, keeping them to where it's familiar. So it's a want to try and meet that, supporting residents in the borough, whether it be ordinary residents for much of their lives or active part of their lives. Yeah.
Jared.
Thank you, Chair. I mean, we touched on some of these issues a little bit, but it's about a range of provision, isn't it? And I'm just wondering, how much do we work with our other providers, Octavia, NHS, Peabody, all those other organisations that are in the borough that could be part of this jigsaw going forward?
We very much do. Octavia is a big partner for us for our day opportunities and our extra care. So we work with them, Peabody, Housing 21, a range of providers, both sort of private and the ones that we work with tightly. So definitely they're part of our range.
I was just going to ask, just generally, how are we capturing residents' views and out of borough moves? So how is that all being captured and used for planning? I think I've sort of touched on it. And then how, in terms of sort of choice, dignity and community connection, will that be safeguarded in terms of if out of borough moves increase? Because, I mean, we are seeing a huge demand. And at the moment, it's whether Lotsford will be able to meet that in, say, 5 years' time. So
we do, as we said before, we do forecasting, as Sharon said before, the best way we can on how many people come. In terms of feedback, I'm not sure if we do a survey. I mean, some people may not be in a mental capacity to complete a survey, of course.
Or their families,
yeah, or whatever else. But I'm not sure who's best to.
So it goes back to the initial assessment. So when assessment is undertaken, there'll be discussion as to what's available. And if there's a preference for in-borough and there's in-borough availability, there'll be discussion around that. And typically there will be the involvement of family members, often people being placed in a care home placement. There may well be capacity issues. And so it will be a holistic conversation with families or people that are part of their network and looking at that and exploring their wishes. It may be that there's a desire to move closer to family members, which are out of borough. We do have a number of out of borough care home placements, but an awful lot of those are in London and surrounding areas. So very accessible for family members to visit to maintain community connections. It may be that there are occasions when, I want to live in borough, but actually the needs are, the availability needs an out of borough placement is made. But that again is about exploring what's an appropriate placement, talking it through with the resident, talking it through with the families. And as we talked about, it goes back to that quality, making sure they're good quality placements and having those quality mechanisms in place to support that. Contract monitoring, quality assurance, and our residential placement management team who will undertake annual reviews to make sure that placement is working for the resident.
There's an ongoing programme around satisfaction and feedback that's sought in the care homes as well, both through the service, but also picked up through our contract managers, because it's about contracts having a nominated person that will go in and visit. And the quality assurance team does the audits as well, so they go in independent to us and sense check how are things working, are people being asked the questions that are appropriate and relevant, and when people have pushed forward a recommendation, what happened to it, what changed? So they're also there to support some of that feedback and satisfaction. And that's done in a number of ways. It's not just a survey, it's conversations and a whole host of ways to try and capture that as well.
Okay, thank you. And then just in terms of, as a committee, us receiving updates on what has just brought up, which obviously might be relevant to Mary as well. But sort of when do you sort of timeline wise do you feel like you might have a sort of forward plan strategy of knowing what I don't know.
Yeah, so for lots
I think that's very difficult.
Yeah, I know. Yeah, it's a very good question. And as I said in previous sessions, we've got a range of works we want to do, not just Lots Road. Obviously, there's Kingsbridge, St Helens Gardens, and Portia's Ward for learning disability potentially. We've got the future of St Mark's Road as well. All the stuff that we are working on right now. And if the committee want, I don't see an issue. We can provide you with an update where we are. Some of them are still very early stages.
Yeah.
For Lots Road specifically, it's not just dependent on, as I said, our extra care, but it's also dependent on planning issues, the monetary issues, the profitability of Mount Anvil and how they're going to achieve that, whether that's worthwhile. The issue of obviously resident consultations. So there's all these moving pieces in place that it's not in our gift necessarily to to give, but
I think relevant.
2029, I think, is obviously the you know, the end date, let's say, but we can provide you with an update on those, I think, periodically, or whatever the committee may want to be.
Yeah. And I think you've got a question.
Good evening, everyone. This is my first time here. I have no idea.
Welcome.
But I've come because my mother is presently in a care home, Alan Mockhill, and we're trying to move her into extra care. She's been in hospital for 2 weeks today, and the manager says he does not want her back, despite the fact that the doctors have declared her medically fit. In fact, she's better than she was when she left there to go into hospital. And he refuses to have her back because he said she needs extra nursing care, which the ward sister says she doesn't, and the doctor says she doesn't. But it seems like everything is overridden by him. So I would like to know, where do I stand in that situation? Because her social worker says, we can't look out the borough. We're only allowed to look at 4 or 5 homes in the borough. So what do I do? At the moment, she's bed blocking. So
yeah, effectively homeless.
Yeah, so I think, yeah, so we won't, obviously, we can't, we'll see you after the meeting, basically, because we can't, yeah, it's probably not appropriate publicly to get into detail, because we're on live on YouTube. But after this, I'm sure my colleagues here will be able to pick that up for you and really take this up as well, because it does sound like an unusual case. But we can definitely look into that for you. But thank you for coming, though. It's a good point to raise.
Can I just ask, because at 5.6, you precisely have 5.7. For example, James Hill House.
Yep.
3 assessment and bedded reablement units for extra care, and at 5.8 it says that precisely 5.9 it's used to support timely hospital discharge. So at what point, when you've got a situation where, and I'm not going to go into details, an individual is not acting how they should act, is taking back a placement, and I think in that care homes you do buy some beds that leave the family completely distraught. At what point the authority can have the authority to tell the provider, this is wrong? Because this is, the NHS team is beside themselves. I have tried, I wouldn't have been here. Every professional has never seen that situation. And we're talking about a very vulnerable resident in this borough.
Sure.
So the provider has a duty of care, and the provider they need to say, we are confident we can meet the needs of that resident. And so provider, if they're saying, we're not confident we can meet their needs, we need to listen to that. If there is a discussion as to, some people say, well, actually elaborate on that. Why do you feel that you can't meet that need? Then that's a conversation between stakeholders. And so typically that will be the professionals and a multidisciplinary professional meeting to explore the case. That's generally what would happen. But fundamentally, providers are CQC registered. It is part of their registration. They do need to be self-assured that they are able to look after the individual appropriately. And so,
I think that's great and that should happen. But I think it's a situation where the individual is not acting impartially, because there's another situation behind it which explains why the person doesn't want the person back, which is not a reflection of the care home with whom we've got an excellent relationship. So that's the blockage here, because it's a specific individual that is creating that situation.
We'll pick that up. Yes, that's right. Yeah.
I think that brings this pictures to close, but thank you.
Thank you.
Thank you.
Thank you.
And speaking first. And moving on to agenda item 6, which is the work programme reports, which report an update of Select Committee's work programme for the year 2024 to 2025 and the development of the 2025-2026 work programme. Select Committee members are recommended to discuss Select Committee's work programme 5, review the proposed items for discussion on the 18th of June. That's out in 3.2. I don't know if anyone has any questions on this.
Madam Chair, maybe on the next action tracker, we'll add those 2 points from the first paper. Thank you.
And so the only comment I would make is that a lot of these meetings are very full, and we do need room to take things at a shorter notice that pop up or issues that become more relevant. So while this is excellent, we need some flexibility to react and respond throughout the year of issues that crop up.
Yeah, I think that's a good point, and it's our recommendation to members is that you don't have more than 3 papers.
We're looking at 2,
Yeah, I totally agree. This is, we're now going into the planning stages for the next.
The next municipal year, yeah.
Are we doing a meeting with that one?
There'll be a workshop on the 2nd of June. We've had a few items through the pipeline already, so I think Councillor Hargreaves, you wanted to have a paper on dentistry and all help, so we'll put that with the June meeting. That's one item, and also an update on police departments as well.
So that's the scrutiny workshop is on 2nd of June.
Yeah.
And when is the next? So French.
That we haven't got a date. That was just working to get a date.
Any other questions?
Yeah, I'd like to know about the, so sexual health and the substance misuse. When are those two?
Come back.
Yeah.
When did we say they would come back?
That was last year,
September.
Yeah.
September, yeah.
We can put them into the programme by. Yeah.
I mean, that's the sort of thing maybe you might have discussed when we had the
workshop.
about if you do want to-
I'm also conscious of 8:30 and everyone's very probably hungry and tired. So that concludes this meeting. Thank you, everyone.
Thank
Nice one.